Well, welcome back, everybody, to our third podcast at Valley Anesthesia. And we're so happy that you joined us yet again. Remember, Valley Anesthesia is doing podcasts now to help fulfill our mission of educating student nurse anesthetists and CRNAs throughout their anesthesia lifespan, we'll call it. So, today, we're going to talk to Dr. Lee Ranalli. He is an expert in OB anesthesia. He's been a CRNA for 13 years. 10 of those years he's spent in education, and he is a contributing author of the obstetrical chapter that you guys all read in Nagelhout, so nurse anesthesia, and we have one of the authors here with us. So Dr. Ranalli had, when I reached out to him, he's also one of our Valley instructors, so yay. Also, he is going to talk to us today about some clinical updates in OB, what's new, what's different. I'm excited to talk to him. I worked in a high-risk OB center for a year in Portland, Oregon, and we did about 800 deliveries a month. There were 3 CRNAs on any given shift and 1 doc, and we would, just work the floor. But lots of crazy things I saw when I was in OB there. A lot of us do, in anesthesia, we're all kind of doing our own anesthetic in our own rooms. So we don't necessarily know what everyone else is doing or how they do it. So it's always exciting, I think, to hear about how other people are approaching clinical situations and managing those situations. So let's have Dr. Ranalli give us any other background or anything he wants to tell us before we get started on some of the what's new in OB topics.
Sure. Well, thank you for the introduction, Michelle. Excited to be part of the Valley Anesthesia team. I guess the only thing to add is I have practiced in obstetrics since I graduated. So all 13 years of practice has involved some form of obstetrics. Nowadays, being a full-time educator, I've on a clinical day, I would pretty much exclusively only practice in OB. And OB, I know it's not for everybody. Some people seem to love it, some people not so much. And when we're interviewing for nurse anesthesia school, the answer typically doesn't involve, I want to be in an uncontrolled environment with multiple patients, all of which the goal is not to provide anesthesia for. So I do think it's a realm of its own. I've grown to love it. It hasn't always been the case, but it's definitely my favorite place to practice nowadays.
That I've never thought of OB anesthesia in that manner, and that is the perfect description. With some, I would say, including some hostile patients and staff and patients being in extreme pain. So don't always make for the most pleasant patients, but it is a beautiful experience to partake in. So although, I still haven't decided myself, I think, whether I sort of have a love-hate with it. But okay, so let's say, Dr. Ranalli, if I asked you, what is the biggest change that's happened in the last 10 years that you think has made a really exciting difference in the OB setting? Anything come to mind?
Sure. I always tend to err in the side of what makes my job more safe, for the patient. What can I do to make the experience overall more safe? I'd say, I don't know if it's the most exciting, but one of the biggest has been the advent of including, TXA in our practice and the impact that it can have for limiting postpartum hemorrhage. There's such great evidence to show that we should be integrating this at times, possibly even prophylactically for patients that are increased risk of hemorrhage. But certainly as soon as it's recognized that there's some form of uncontrolled bleeding, it should be one of the first go-tos in our protocol. And unfortunately, it's not always stocked within the obstetric operating rooms, not even always stocked within the maybe more central Pyxis system of the obstetric floors. So certainly I do think that's a quality improvement that all facilities should be making. It should be readily available for anesthesia or obstetricians to be able to order or administer that gram as soon as they recognize that uncontrolled bleeding. So I do think that's one of the larger, most evidence-based changes that we've had in recent years.
So the administration of the transexamic acid is basically something that your OB would say, hey, I think we're getting a little bit, or you might say to the OB, it looks like we got a lot going on in the suction. And what do you think about a gram of TXA?
Yeah, kind of both, depending on the situation. So, for example, if it's a planned vaginal birth, the anesthesia provider might be in a call room or somewhere else, and we don't know that anything's going on abnormally. And so there are times that, I'd get called from the call room saying, hey, we need you in labor room blank. We have a suspected hemorrhage, or there is a hemorrhage. And one of the first questions I ask before I'm on my way over is, have you guys administered TXA as of yet? And if not, can you go ahead and get that available and running while I'm on my way? And so when it's in the operating room setting, obviously it's more, hey, I could see the suction canister, or I can hear the suction at the very least as well. And it start to communicate with the surgeon, like, hey, it looks like we're having an abnormal amount of bleeding. What do you think about a gram of TXA? And at least where I work, I have very little resistance to moving to that treatment modality.
Now, are you working where you do OB? Is your setting a university setting? Is it a private hospital? I'm just wondering if there's any difference in how frequently this would be incorporated into an OB setting, depending upon what kind of OB setting you were working in.
Yeah, so much as a community hospital, moving to high risk, about 400 to 450 deliveries a month as of now. But I would say anything from a critical access hospital to a large teaching institution, this is something that should be, housed and stocked within their unit, within their Pyxis of the operating rooms and the central Pyxis for the OB nurses to be able to gain access to as well.
Okay. Okay, great. So coming to mind, something that we had just talked about previously before we started was also helping for safety reasons, hypotension. What kind of treatment are you doing these days to help stave off that hypotension right before you pop in that spinal or other kind of anesthetic?
Yeah, so before we'll say spinal for C-section, in addition to the classics such as left uterine displacement, and of course having your vasopressors such as ephedrine and phenylephrine available, I'm more of a co-loader. So traditionally we've been taught, preloading. I've worked with some that won't even approach the patient in more of an elective case if the patient hadn't received at least 1 liter of crystalloid. That's not necessarily my approach. I'm more of a co-loader. The evidence tends to support it and show that it mitigates hypotension, more beneficial than preloading. And so as long as they have a good IV and it's running concurrently while I conduct a neuraxial anesthetic, whether that's an epidural or a spinal for C-section, I'm fine with that. The other change would be ondansetron prior to the administration of spinals. And so this is thought to be due, at least in part, the hypotension and potential bradycardia associated with the Basal-Gerish reflex. And this is thought to be a 5-HT3 mediated pathway, and such giving a 5-HT3 antagonist is thought to mitigate this potential vital sign instability. So for me, the risk to benefit, there's really not much risk and potential benefit. So I started incorporating Zofran into my preoperative cocktail. I tend to give it just prior to heading back to the operating room, usually in combination with Bicitra for the patient. So that's kind of my flow of things when it comes to administering Zofran. So there is some literature to support that it can assist in mitigating blood pressure swings and heart rate and bradycardia in those circumstances.
And that's a 4 milligram dose you're giving?
I'm given 4 milligrams. I haven't seen literature to suggest more than that is more beneficial, if that makes sense. And what's kind of interesting maybe to add is that there is a little, bullet point that the AANA, Analgesia and Anesthesia Obstetric Practice Guidelines, they even mention considering administering 4 milligrams prior to the spinal for cesarean for that mitigation of hypotension.
Okay, great. Something that I saw on the list that you were going to talk about that I thought was really interesting was, tell me about the transnasal sphenopalatine block for your pregnant patient. What are you using that for? Tell us about that.
So I think it has a place in obstetrics. However, I think as providers, we have to be cautious about our approach to it. It is a fairly easy procedure to conduct or to learn for those who are not familiar with it. But when it comes to like post-dural puncture headaches, the traditional treatment conservatively has been fluids, analgesics, caffeine, all of which have not proven very effective when you have a true post-dural puncture headache. The more aggressive curative treatment has classically been the epidural blood patch. So we haven't had this middle of the ground, route of treatment. And I think the transnasal sphenopalatine block can serve that purpose. And so mostly for patients, I would say, who maybe have post-dural puncture headache symptoms resulting from spinal anesthesia, where the needle is smaller and will likely take less time to heal at that point, and you're just trying to buy them some time. Those patients could benefit, or maybe the patient refuses an epidural blood patch. They just went through an epidural. It's now creating a terrible circumstance and experience for them. And if they've been punctured once, they're likely at higher risk of being accidentally punctured again, worsening what they have going on. And so it may prove useful for those type of patients as well.
I was recently just reading, I think it was a blog or something about a recent research study that had come out that said delaying an epidural blood patch, not placing it immediately within the first 24 hours of delivery, they found better results if it was actually placed after those first 24 hours. Am I remembering that correctly? Have you heard of this?
Yes.
Okay.
So it's a good point. For example, most headaches are typically after the 24 hours. And so that's what's nice, which matches the literature, is that we're not typically being called for like an epidural blood patch evaluation until at least 48 hours after, the puncture. However, if they were to experience the symptoms beforehand, this phenylpalatine block might buy you some time until that 24-hour mark, in which that is when, most of the recommendations within the literature that I've seen is to administer and do that procedure after the first 24 hours for potential increase in efficacy.
Okay. All right. And then other thing, I remember when I was doing OB, this was a point of great contention among all practitioners that I worked with, and even with some of the OBs who, of course, would, when they really wanted you to place that neuraxial anesthetic, they would say, oh, it really doesn't matter in this patient, but it's the platelet count thing. Everybody has their line in the sand related to platelet counts and where they will and will not place. So what's the latest and greatest on the platelet count and neuraxial anesthesia for us?
Sure. And I always caution, whether it's SRNAs or CRNAs who I'm talking to about this, I always caution them about setting that number to an exact number, because almost promise you that soon after you will get somebody with a platelet count, 1,000 below that number. So, but what the literature kind of states is I don't know about much different, but I would say I trained at a time where, and at a facility, which if they were less than 100,000, they weren't receiving a neuraxial anesthetic. And so, looking at the data now, I would say it does tend to range still, but that even the AANA practice guidelines I referred to earlier says, a platelet count likely greater than 70, depending also what other comorbidities the patient has going on, whether this is an idiopathic finding in somebody who's relatively healthy versus a severe preeclamptic, whose platelets have been trending down, your approach might differ. But having said that, a platelet count 70 or greater, that there's a very low likelihood of spinal epidural hematoma occurring. And so my personal approach is because epidural procedures are elective, we don't have to intervene at that time, and we're using a larger bore needle. I tend to err on the side of about 80,000 and above, once again, depending on their comorbidities. For spinal, where now we do have to intervene, they're going to have a cesarean section, and I get the opportunity to utilize a smaller gauge needle. My number trends more to that 70,000 and above.
How do you handle, I guess I'm just thinking of when this was an issue for me. It came up one time in my year when I was doing the high risk OB. I had a patient with documented preeclampsia, and I had a very aggressive nurse who wanted that epidural now, and the blood work wasn't back yet. And I just said, as soon as the labs come back, I'll be happy to go put that in. And she then called the OBGYN, and then he called me and said, I want you to go put that in. And I said, well, we don't have any lab work back, and you have this documented in the chart. And he's like, oh, that was just a soft call. It's a soft call. Don't worry about that. She's not really preeclamptic, and I'll take responsibility. And I'm like, well, you didn't work as hard for my license as I work for my license. So I think I'm gonna wait for the blood work to come back. I did end up calling the MDA who was on call that evening because they weren't in-house, and she was just like, yeah, just stall, just take your time. It'll be back soon enough. And then I wouldn't go in there and do it until, it's in the chart. So how do you deal with situations like that, where you might be getting someone to kind of push? We all are taught this in school, we got to stand our ground and do what's best for patient. But I always love to talk to other CRNAs, how they handle and sort of get through those sketchy times, but still, do what's best for the patient. I always like to hear how people manage that. I'm sure some of this comes up in your practice as well.
100%. So I have the fortune of being at the same place for so long. And so they know usually when I'm holding my ground on something, there's usually good reason. However, there's times where there's, a traveler nurse or people who don't know me quite as well, especially with me being in education and not working as much clinical, there's more, not as many familiar faces when I do clinical practice. So I would say, a routine platelet count on an otherwise healthy patient, but we shouldn't be holding up a neuraxial anesthetic for. But as you mentioned, a preeclamptic patient, or even in my circumstances, if they didn't have prenatal care, if they have gestational hypertension listed, and doing further workups, then I want to see that number back prior to moving forward with placing it. And it is one of those things. There's typically multiple anesthesia providers at the facility, and there are times where if I'm just at a standstill, hey, you're more than welcome to call the other anesthesia provider to see if they have an alternative opinion. But at this time, until those labs are back, which usually isn't very long, by the time another anesthesia provider gets here, they'll likely be back. I'm not going to move forward personally with conducting that procedure. I don't think being pressured into efficiency should outweigh patient risk. And unfortunately, especially new graduates or maybe providers who are just finding themselves back in obstetric anesthesia or trying to establish a good reputation, hopefully they're not cutting corners in the name of efficiency with potential increased risk of an adverse outcome.
Yeah, I do think that we're often put in the line of fire when it comes to that efficiency process, whether it's in the OR or even in OB. They just, when they want to cycle to the next patient and don't want to take the time that we need. I always say it's a pressure cooker, right? Because we're the last one with the last patient, but the first one with the next patient. So while other people may have had 30 minutes where they're not interacting with the patient, we've always been with the patient. So we do need that time to properly evaluate our patient and make sure that all the things are back. We have all the information we need to safely see that next patient through to their next surgery. So let's see, how often are you using neuraxial ultrasound, placing epidurals? And are you just using those for the more, the heavier patients, the more obese patients? Are you using it for maybe patients who have scoliosis that they have some spine deformity and they might not be midline? One of the things I've seen with my colleagues and talked to when I, was the director of simulation in one of my previous jobs as faculty, we incorporated a lot of ultrasound and teaching students how to use the ultrasound on the back to kind of make their way through the back to place spinals or epidurals is invaluable. What I see out in practice is a lot of CRNAs who they're just not familiar with the technology. They don't know how to read the technology just yet. And I think it's just a matter of time of getting exposed and getting someone to teach them. And then after that, just regularly using it on patients to get familiar with it. I mean, that's how all practice changes happen, right? Is it something that is terribly complicated that, can't be learned by a CRNA who's 20 years out and maybe didn't train with it in school? And how can they go about getting that technology and getting that education that they need?
Sure. So I will tell you, similarly to what you said, when it started becoming more common and with me doing as much obstetrics, I wanted to become familiar with the ability to do my mapping via ultrasound, in which if I felt the patient was a good candidate, they're able to sit still, they're not pending delivery, and I can spend a couple more minutes with my process without hindering their care. Those were the type of patients I was doing it time and time again before I became, comfortable with the procedure itself. Once I became comfortable with it, then it's, as you mentioned, saving it more for patients that you're just having troubles with, or maybe they have an identified problem ahead of time. Hey, the last anesthesia provider stuck me 6 times, whatever it is, or I've never had an epidural work. And so for those patients, as you mentioned, scoliosis, maybe they're larger with a history of difficult placement, it can be useful for that inner space identification, midline identification, more accurately than our traditional assessments. Also can give you that prediction of epidural depth as well. And so it does have its purpose. I think it's worthwhile for people to practicing an OB to take it's offered all the time in ultrasound type conferences. There's websites dedicated to the landmark techniques, utilizing ultrasound and what you can see, and kind of counting the inner spaces to know where you're at. I will say the biggest challenge I've had with it is, if a patient isn't in any sort of pain and they're not they have a history or they are proving to be a difficult epidural placement, is you can map them out all you want, and it'll give you an idea of midline and interspace. But as soon as they move, it's certainly not as reliable, since we're not doing this under live ultrasound. And so they get a contraction, they start to move, and then you reposition them. It may not line up perfectly, but it can give you a better idea of where you're at. Additionally, some facilities, such as my own, invested in a device called the Acuro, which is by Revonic. It's kind of
Yeah.
this little
Mhm.
handheld device, and it kind of looks like a video game almost when you're doing it. But it's
Mhm.
fairly easy to learn. I even know some independent contractors in the area who purchased one on their own and take it facility to facility. Those who do a lot of neuraxial techniques. So ultrasounds have become fairly common in the hospitals and facilities. And even if it's not available, there's these options such as the Acuro that somebody can go and purchase one for themselves, to kind of accomplish this.
Yeah, I think that's great advice as far as, practicing when you're learning, practicing on the easy patients, the ones you can take the extra time with, and really getting used to the equipment, and then building up that skill set. So when you want to use it on the difficult patients, you understand the technology and what you're looking at, and then you can get really effective information out of it that you normally can't when you're not using it, right? Because it's almost like a pair of eyes on the other side of the skin for you. And I am familiar with Acuro. Last year, Acuro had a special that they were offering to all the schools of nurse anesthesia. You could, if you filled out their form, they were willing to send a device to your program to use in your program simulation center. So I don't know if they're still doing that, but it was something that they were doing about a year and a half ago that I remember. I had filled out the paperwork for the program I was working for at that time. It was a really neat device. So in your department, do you have a dedicated ultrasound machine on the OB floor?
So we have a dedicated Acuro on
Okay.
the floor, and then if we wanted the curvilinear, ultrasound probe and device, then we would just either call down for it or go get one if there wasn't one available on the unit.
Okay.
But yes, both the traditional ultrasound means as well as the Acuro are available at my facility.
And being a really experienced OB CRNA, how often are you pulling that out to use that, do you think? I mean, you work in a high risk setting, so I would think maybe you get more of the dicey patients. But
Well,
you can get a dicey patient anywhere that just walks in the door with no prenatal care. So just curious how often you actually end up using.
yeah, they're in the process of becoming high risk, and I would say not very often, but I'm glad to know how to do it, because when I am moving to a particularly challenging epidural, or once again, a patient who comes in who has scoliosis and you can't palpate any of their landmarks, it's a useful skill to have. So it's pretty rare that I actually need it, but when I do need it, I'm grateful for the ability to move forward with it. And once again, for more experienced providers, it's less likely to be of benefit. Or if you can palpate the patient's landmarks, it hasn't really shown to be beneficial, which makes sense. But overall, it is something worthwhile in the toolkit of those who are practicing OB. Once again, whether it's at a small facility or a large facility, it can prove of use.
Yeah. Okay. So I think we have time probably for one more topic. So is there any special topic on that list that you sent to me that you'd like to actually talk about um, that we
Um,
haven't talked about yet?
I mean, maybe we can do the AOK regimen
Yeah,
for
let's
fluid
do that. Let's do the
embolism.
AOK. Yeah, because
So,
that's
so
rare but important to know.
it is rare, and just randomly, I was talking with somebody today who was recently handling a fluid embolism experience on one of their patients. So although it's rare, it's not unheard of. And so essentially, if you're undergoing, say, a cesarean section, um, the patient starts to experience sudden cardiovascular and respiratory collapse. They may be experiencing amniotic fluid embolism. as evidenced by the hypoxia, the hypotension, the pulmonary edema, and can potentially be followed by hemorrhage and complicated by DIC. And so in addition to our traditional supportive care, our ACLS or BLS, we're obtaining the airway, we're doing compressions if necessary. The AOK protocol stands for atropine, ondansetron, and ketorolac. And so the dosing varies on some of these in the literature, but the atropine dose typically cited is a 0.2 to 1 milligram, IV dose. And this is to help assist with that vagal predominance that's occurring and also improve the vasomotor tone. Ondansetron, commonly listed about 8 milligrams, and working as a serotonin antagonist, is thought to either block the impact or the release of further mediators. And then ketorolac ranges between the 15 to 30 milligrams, but by blocking that thromboxane production, may help prevent issues with coagulation down the line. So it's not substituting the AOK protocol for any of your traditional treatment, but just adding it, into the repertoire. Yeah.
So I have a question for you. If I'm doing an AOK protocol, let's say we're towards the end of the case and I've already given ondansetron, am I including what I've already given in that 8 milligrams, or are these numbers for at the beginning of when you recognize that this is possibly an AFE?
Yeah, it's a good question, and probably going to be provider preference at that time.
Okay.
If I already gave 4 milligrams recently, I would probably just give another 4 milligrams at that point, just off the top of my head. And unfortunately, fortunately and unfortunately, fortunately, these are rare. Unfortunately, when you have rare events, it's hard to get really good data from it.
Sure.
And so we love to provide credit to the novel treatments, but in reality, there's no way to conduct a randomized controlled trial. It's based on theory and expert opinion a lot of times, and then the case studies that ensue. And so I think there is good enough case study reports. The person I talked to, as I mentioned earlier today, did integrate this into the treatment protocol and ultimately did have a good outcome. Was that from the traditional treatment? Was that from the AOK? Was it a combination? Yeah, likely a combination. But once again, I think that the rationale is there to integrate it into your treatment algorithm. And, if I was to be the one caring for this type of situation, I'd certainly administer those agents.
Sure. So, well, thanks so much for being here with us today. And I just want to go over just a couple of the things that recap a couple of the things that we talked about. If I misstate anything, hop in here and correct me, please. First, we talked about safety, improving patient safety through the administration of TXA for uncontrolled bleeding. When uncontrolled bleeding is recognized in the obstetric patient, the sooner we can get the gram of TXA on board, the better. We talked about co-loading versus preloading, and as well as a dose of Zofran 4 milligrams IV at the time of neuraxial anesthesia. That helps with some of our hypotension that we see in our patients at that time. And we also talked about relief of the post-dural puncture headache, not from the traditional epidural blood patch, but from a transnasal sphenopalatine block. And whether we use that and they get total relief, or that buys us more time for an epidural blood patch later, or some of the other conservative treatments that we can do, we can just add that to our toolbox. Then we went over what is the best platelet count when we place neuraxial anesthesia. And AANA, we said their practice guidelines advocate for greater than 70K. I'm with you, Lee. When I was in school, and even that year I was doing high risk OB, 100 was like the magic number. But like you said, it's important to evaluate the patient. Are we talking about a healthy patient? Are we talking about a patient with a bleeding disorder? Or are we talking a patient with a live pathology such as preeclampsia. So it really matters where we want to put that number. We have to take into account the complete picture. And then we talked about neuraxial ultrasound and getting more practitioners comfortable with this, because like you said, it's a great technique to have in your toolbox for those really difficult patients that you might be struggling in, although not needing to use it on a regular basis is common, but practicing on those easy patients is a great way to get your skills up, and then you feel very comfortable using it in those situations where epidural or spinal placement becomes difficult. And then we wrapped it up with the AOK protocol for addressing amniotic fluid embolism, which of course it does not substitute for the hemodynamic support and ventilatory support that we would do for an AFE, but this is on top of that because it's research based, and it's the use of atropine, ondansetron, and ketorolac, in addition to all those other things to help improve patient outcomes. Did I do it right?
You hit it.
Okay.
Appreciate you having me. Yeah, good summary.
Okay. No, it was a lot of fun hearing about all this stuff. Now I want to go put in a labor epidural. So, but not have an AFE though. Anyway, thanks so much for spending some time with us. And everybody, remember, Lee is one of our expert lecturers for our Valley reviews. So he's got a lot of good information. He's a great addition to our team of lecturers, and we're very excited to have him with us and to share his talents with Valley Anesthesia. And if you have a topic as a listener that you might want to hear about, feel free to shoot us an email at support@valleyanesthesia.com. We'll do everything to try and locate a local expert who we can get on our podcast. Lee will be back again, I'm sure, to share some of his other specialty areas that he feels passionate about, and we appreciate him being here today joining us. So until next time, from us at Valley Anesthesia, we say thanks so much, and thanks for using Valley.
Yes, thanks so much. Appreciate it, Michelle.